Good morning, everybody. Thank you for coming this morning. On behalf of the Alumni Society this year, it's been a privilege to serve as the president and to organize this two-day meeting that we've had on immune checkpoint inhibition and some of the clinical challenges and controversies. And I just want to take this opportunity to acknowledge the two winners of this year's alumni event as well, and the Distinguished Alumni Awards, both Dr. Paul Chapman, who's sitting over there. So congratulations, Paul. And Dr. Jedd Wolchock, who is up front and will be speaking today. Congrats, Jedd. And I think it's really to the credit of these two that the survival from advanced melanoma has increased from a 10% historical rate to well over 50% now at this point, and we're going to be hearing about some of that today from Dr. Wolchock and his contributions. So just to briefly introduce Jedd, many of us know him from all of his work here, but Jedd's really the consummate physician scientist here, and not only a fantastic oncologist and laboratory researcher, a really great person, and all of us who know him and have worked with him in various aspects really just know what kind of family that he's created for us. And I think that's something that speaks to his qualities as a person, incredibly important for my own career development, and I'm eternally grateful that he was able to kind of take us all into the melanoma family. So Jedd has been here at Memorial for a couple of decades doing work with immune checkpoint inhibition, running a laboratory and leading clinical trials, first with many different agents, but most notably ipilimumab, and then developing the combination of nivolumab and ipilimumab, which has really expanded beyond melanoma to many different malignancies. So we look forward to hearing about that today, and I'll turn it over to Dr. Wolchock for the rest of the morning. Thank you all for your attention and attendance.
Thank you, Mike, and thank you for so wonderfully leading this entire alumni event. You've done a fantastic job, and we all had a terrific time last night, so thank you again. Just to start off with disclosures. As Mike alluded to, one of the first opportunities that we had to explore the current generation of immune modulating antibodies was in the early clinical development of ipilimumab. And just to go through a little bit of the mechanistic rationale for why we think that CTLA-4 is important. When a T cell sees an antigen with its highly polymorphic T cell receptor, here recognizing the peptide MHC complex, that interaction, which immunologists term signal 1, is insufficient for the T cell to become activated. It needs to be accompanied by signal 2, here symbolized by an interaction between CD28, a molecule that Dr. Thompson knows very well, recognizing a member of the co-stimulatory family. And here, these are termed CD80 or CD86. They're also called B71 or B72. One thing you'll notice about immunologists is they like to give 2 or 3 different names to the same molecule. It maximizes the opportunity for any one person to become famous. So I'll try to be consistent throughout here. But when the T cell receives these 2 signals, it becomes activated. You get a productive immune response. IL-2 is produced by the T cell, and all of that activation takes place in this immune synapse. However, at the same time, there's another molecule called CTLA-4, which is here symbolized by this orange fork, which normally resides intracellularly. And CTLA-4, when the T cell becomes activated, translocates into the immune synapse, shown here, where it outcompetes CD28 for binding to these co-stimulatory molecules. And in addition to outcompeting CD28, it generates negative signaling into the T cell. And one of the reasons why Jim Allison won the Nobel Prize last year was for his hypothesis that by blocking CTLA-4, you might allow T cells to override this inhibitory influence and become more activated than this normal physiologic governance would allow, and perhaps overcome some of the immune suppression that accompanies advanced cancer. And so he hypothesized that if you blocked CTLA-4 with an antibody, you might allow for a temporary period of immune activation. We know that CTLA-4 is a non-redundant molecular brake, which keeps the immune system under control because of the work of Varlene Sharp and Tak Mak, who both generated knockout mice that lack CTLA-4, and these mice actually die at about 3 weeks of age of fulminant lymphocytic infiltration of many organs. So it's clear that wholesale loss of CTLA-4 is not compatible with life. But Jim hypothesized that if you could block it temporarily, like with an antibody, you might allow for a controlled period of sort of immune hyperactivation. And so then from Jim's work came this, until recently, unpronounceable word, ipilimumab. Jim is fond of saying that if the FDA had any respect for the Berkeley roots of ipilimumab, which is really where this work was done, they would have put an H at the beginning of it, and it would have been called hipilimumab rather than ipilimumab, but I guess the FDA doesn't have that sort of sense of humor. So we had the great privilege of participating in some of the earliest clinical trials of ipilimumab in patients with advanced melanoma. This is a patient, as you can see, that was treated on a clinical trial here at MSK in 2006. So now going on almost 13 years ago. And she had very advanced melanoma with this palpable dermal and subcutaneous disease, which covered most of the anterior part of her thigh, in addition to a large pelvic mass. And she had received best care at the time from Anna Pavlik at NYU, another proud MSK fellowship alum. And Anna had treated her with dacarbazine and also with the best BRAF inhibitor that we knew at the time, which was sorafenib, and also on a clinical trial with an anti-integrin antibody, and the disease was just progressing nonetheless. So with very advanced disease, a high LDH, and a quite considerable disease burden, she enrolled in a phase 2 study of ipilimumab, and within actually 2 doses, so 6 weeks later, all of this palpable disease regressed. And that was quite striking, but you could see that there were still some areas of hyperpigmentation left on her thigh. And actually, when she came back for this visit, I believe I was away, and actually Paul saw her and had the good sense to biopsy one of these hyperpigmented areas. And Klaus Bussam interpreted Paul's biopsy as being a tumorous nodule with melanin pigment accompanied by macrophages and lymphocytes. So this is essentially the inflammatory debris of melanoma, which had regressed. So melanin is a highly insoluble heteropolymer of tyrosine. When a melanoma tumor dies, it leaves behind its melanin pigment, which may remain for many years as sort of a tattoo of where the melanoma was. And so this is what this lady's leg still looks like today. But this presence of macrophages and lymphocytes shown here, and then on immunohistochemistry, CD8 positive T cells, and to a lesser extent CD4 cells. This was a very nice visual proof of principle that what Jim Allison had hypothesized, that if you blocked this critical co-inhibitory molecule, you would allow the immune system to replace a tumor with a very, in this case, constructive immune infiltrate. And that's exactly what happened, and this patient remains alive and free of disease. So Mike alluded to this. So where we stood after ipilimumab, this is a pooled analysis of patients in phase 2 and phase 3 trials of ipilimumab that was put together by Dirk Schadendorf a few years ago. And you can see that the survival curve here plateaus out at just over 20% for 5 years or longer. So all these patients have been followed for at least 60 months. And that is a rather depressingly shaped curve, for sure. But for melanoma doctors, it actually was, it was pretty good, because this is what we were used to seeing. And so this was state-of-the-art, actually published by Paul, a large intergroup trial of dacarbazine versus combination chemotherapy, a regimen called the Dartmouth regimen. And the actual plateau here was somewhere around 3% for longer long-term survival. And so even though there is a steep drop-off here with just ipilimumab alone, it was better by quite a bit compared to what we were used to seeing. And so this served as, I think, an important foundation for opening up the study of other checkpoints. It also opened up the possibility for us to understand a new class of adverse events, which the audience at the Alumni Symposium heard a lot about yesterday from relevant MSK experts who have really done amazing work in helping us to manage the toxicities of these immune checkpoint blocking drugs, which can range from relatively common things like rash, which Mario Locatore has been instrumental in helping us to manage the dermatologic manifestations, to enterocolitis. The GI group here has been extremely helpful to us. Elevations of AST and ALT, quite common. And all of these actually are quite reversible with usually single-agent corticosteroids. Rarely we do need to go to second-line agents, in the case of the enterocolitis, TNF blocking drugs, or for the liver toxicity, mycophenolate. But in general, this is very manageable in an algorithmic manner. The endocrinopathies have generated a lot of patient volume for the endocrinology group here, and we're really grateful to them because the endocrine toxicities, the thyroiditis, the hypophysitis, and the adrenal insufficiency are not easily reversible. Patients are left with long-term endocrine gland dysfunction, and in the case of PD-1 blockade, type 1 diabetes has emerged as sort of a signature adverse event for that. So the endocrine organs do not seem to rebound as well as, say, the skin or the GI mucosa or the liver from this inflammatory insult, and these patients are left with long-term hormone replacement. Through outstanding collaboration with our nursing teams, we've actually learned that being vigilant in terms of surveillance and good communication and education with patients and their families is key to intervening in an early manner and really getting these things under control. However, just in a hat tip to this little headline over here, this was set off by a small number of patients who developed fatal myocarditis, and actually Dipti Gupta from the cardio-oncology group here has been really a leader in this area and in helping us to understand how we might screen for this very rare but very highly lethal toxicity, which we really don't yet have conclusive answers for. So this is just a snapshot of some of the organ systems that have been affected by checkpoint blockade, and just another sort of nod to Bianca Santamasso, who has really been critical in helping us to understand mechanistically what is underlying this neurologic toxicity and how to manage it. More recently, actually, the group in my lab, specifically Alison Betoff Warner, working alongside former MSK research fellow Yoshi Nishikawa, who is now the head of immuno-oncology at the National Cancer Center in Tokyo, has been studying mouse models of how corticosteroids might convey a beneficial effect in treating the toxicities, but don't seem to really get in the way of the anti-tumor activity of the immune checkpoint blockade, in this case ipilimumab. And in some recent data that was in JEM just a few weeks ago, we actually showed that the schedule of how steroids are given in a delayed fashion in response to the toxicity rather than in a prophylactic manner is critical in maintaining a therapeutic balance for dampening the toxicity but not getting in the way of the anti-tumor activity. And in addition, there seems to be a differential effect of steroids on high affinity memory T cells compared with lower affinity T cells. And this is actually quite fortunate because it allows some uncoupling of this corticosteroid effect. And in fact, this occurs through a differential effect on fatty acid metabolism of corticosteroids in low affinity versus high affinity T cells. So we're learning a little bit more about this, and hopefully we will develop even more refined ways of intervening against these toxicities. So as I mentioned, the relative improvement in survival for melanoma patients using ipilimumab, and ipilimumab was the first drug ever to improve overall survival in melanoma. It was closely followed by vemurafenib in that same setting in studies that were actually pioneered and led by Paul Chapman. Ipilimumab opened the door, really, to investigating other immune checkpoints. And as you all well know, the other checkpoint which has received a lot of attention is, of course, PD-1. And PD-1 stands for Program Death 1, was discovered by Tasuku Honjo at Kyoto University, and for which he was awarded the Nobel Prize in 2018. PD-1, like CTLA-4, is found on activated T cells. It is upregulated after T cells become activated. And it integrates with a few different ligands, which have been termed PDL1 and PDL2. And under normal immune physiologic conditions, in the absence of cancer, PDL1 and PDL2 are mainly found on antigen-presenting cells and on some endothelial cells. And they mediate inhibitory crosstalk, like CTLA-4 does, in this case between a dendritic cell and the T cell. And that inhibitory crosstalk is mediated by SHP2 and leads to silencing of signaling from the T cell receptor. And so that molecular mechanism is fairly well worked out. What was surprising and was very important in pushing this pathway forward as a cancer therapeutic was the identification of PD-L1 on the surface of some tumor cells. This really provides a very clear rationale for blocking this pathway as a cancer immunotherapeutic strategy. And all of this science really came together through a lot of people's work. As I said, Professor Honjo really first identified PD-1. Arlene Sharp and Gordon Freeman, along with Liping Chen, were critical in understanding the interaction between PD-L1 and PD-1. And in fact, it was actually Liping Chen who was the first to block the PD-1 pathway in mouse models as a cancer therapeutic advance. So this was really a team sport in terms of understanding how this might be deployed as a cancer therapeutic. The presence of PD-L1 on the surface of tumor cells is a really clear example of how tumors actively seek to evade the immune system. Because the expression of PD-L1 is induced by cytokines such as interferon gamma in response to the T cell coming into the tumor microenvironment. So this has been termed adaptive resistance by Suzanne Topalian and Drew Pardal as a way of the tumor cell really defending itself against a T cell that has entered its microenvironment. And because of this very clear rationale, there has now been a proliferation, shall we say, and I would say too many medicines that have now been approved that block the same interaction. 3 different medicines that all block the PD-1 receptor, and 3 different antibodies that block the PD ligand 1. And I'm not going to start the immunology street fight as to whether it's better to block the receptor or the ligand, and I'm not going to get into any discussions about whether any of these are better than the other. I'm just actually going to say that from the point of view of a humble melanoma doctor, where we have a lot of experience with both pembrolizumab and nivolumab, these look identical for the treatment of melanoma. Why there are 50 others in development, I don't have enough time to get into why that's not a great thing to do. But in melanoma, we became aware early on that blocking PD-1 was an important therapeutic strategy. This is data from the KEYNOTE-1 trial, which we were one of the lead sites on. It was presented by Tony Ribas first at ASCO and published by Caroline Robert. This was the melanoma cohort from KEYNOTE-1, which looked at pembrolizumab in either patients who were previously treated with ipilimumab or those who were naive to it. And you can see the take-home message here is that there's about an equal number of yellow and blue bars, implying that prior refractoriness to PD-1 blockade does not, to a CTLA-4 blockade, does not portend response or resistance to PD-1 blockade. And this is obviously a great source of hope to patients, knowing that the actual response rate to ipilimumab was only in the neighborhood of 15%. This opened up the opportunity for these patients to have a therapeutic benefit from PD-1 blockade. We went on to then understand, actually, that because these two pathways diverged mechanistically, even though they converged on the T cell as the ultimate really drug in treating the melanoma, the fact that there were divergent mechanistic pathways allowed us to think about combining them as a way to look for additional activity. And this is just a schematic as to why. In about 2009, 2010, we became one of two sites to begin to explore the combination of CTLA-4 and PD-1, along with our colleagues Mario Snall and Harriet Kluger at Yale. And we looked at different doses of ipilimumab to block CTLA-4 and nivolumab to block PD-1 in a dose escalation trial, and landed on sort of the approved dose of ipilimumab and a somewhat lower dose of nivolumab, even though this is a dose that is able to easily saturate all of the PD-1 receptors for many months. It's still a little bit lower than the indicated dose. But with this combination, for the first time, we saw more than half of patients having quite rapid and durable responses. And this is just an example of a patient treated by Dr. Kluger at Yale, who had really multifocal, bulky disease, which all regressed by the time of the first imaging. Eventually, this went on to both phase 2 and phase 3 clinical trials. I'll just hat tip to Mike Postow, who actually led the phase 2 trial called Checkmate 69, which actually led to the approval of the combination of CTLA-4 plus PD-1 blockade in patients with advanced melanoma in the US in 2015. But the phase 3 trial, I'll just go through a little bit more slowly because we just published the 5-year survival data about 2 weeks ago. So this was a worldwide study which was actually designed by the team here at MSK, by myself and Mike and Dr. Maggie Callahan, as well as a former fellow, Arvin Yang, who at the time was working and still is working at Bristol Myers. And we designed this as a 3-arm trial as first-line therapy for metastatic melanoma, the combination alongside nivolumab by itself or ipilimumab by itself. And these groups were stratified by BRAF mutation status, M stage, and the tumor cell expression of PD-L1. It was 945 patients at 137 sites around the world. So this is the data that was just published a few weeks ago in the New England Journal by James Larkin from the Royal Marsden. And what it shows is that the combination group actually still has not reached a median overall survival now with 5+ years of follow-up. So 52% of patients still alive for 5 years or longer. So let's just pause there for a second and think about how much things have changed in a relatively short period of time. When we, in the past, were very much used to hearing about less than 5% 2-year survival. Now we've got 50+%, 5+ year survival. And I think that it's important to consider that this is not just due to ipilimumab and nivolumab, but it's also due to BRAF and MEK inhibitors, which patients who progressed may have also received. But for patients with melanoma now in 2019, the outlook is actually quite a bit better than just a few years ago. So for the combination, we haven't reached a median OS. For patients who are initially randomized to nivolumab alone, there are 44% of those patients still alive, and those patients initially randomized to ipilimumab alone, 26% continue to survive. This is looking at survival metrics depending upon the stratification by BRAF mutation status. It looks like there's a wider separation between the combination and the nivolumab alone in patients who have a tumor that has a BRAF mutation as opposed to those who have a wild-type tumor. We're still trying to mechanistically understand that, but it's an interesting and reproducible finding. And if you look at patients stratified by their serum level of LDH, which is sort of a poor prognostic marker when the LDH is elevated, there is activity across the different LDH cutoffs. We initially believed that there was going to be an importance in tumor cell surface expression of PD-L1 in terms of the activity of the combination versus PD-1 blockade alone. But indeed, now with many trials and longer-term follow-up, we see that there's no optimal cutoff in melanoma for tumor cell expression of PD-L1, so we don't measure it. And there is no easy way to use PD-L1 expression as a rationale for selecting combination therapy over single-agent PD-1 blockade. So we still are actively seeking biomarkers to help us make that decision. The response rate by RECIST criteria has stood up across the phase 1 through 3 trials. So for the combination patients, the best objective response rate is nearly 60%. For the nivolumab alone, it's 45%, and for ipilimumab alone, it's 19%. For the 2 nivolumab-containing groups, the median duration of response has not been reached with 5+ years of follow-up. Now, when we looked at subsequent therapies, there of course has been the use of subsequent therapies across these different groups, and this is just a snapshot of which patients in which group received which therapy. In actually acknowledgement of interest that actually was generated by observations that Mike made to look at longer treatment-free intervals. So with an understanding, as I will get into, that the combination actually has a much more difficult toxicity profile than nivolumab alone, we wanted to really understand, you know, the three-dimensional benefit, if you will, of giving the combination if one exists. And so, yes, we can see a modest improvement in OS, a modest improvement in response rate, a very steep difference in toxicity. But what we see is that for patients who are initially treated with the combination, the treatment-free interval is remarkably long for patients who discontinue study therapy. And these are actually mainly patients who stop because of toxicity. And so this becomes really another way to think about this data, that patients who initially receive the combination and have to stop treatment because of toxicity actually do extremely well, probably because the emergence of toxicity is an indicator that we've hit the mechanistic endpoint, really, of activating the immune response. I think more time will show us how to get a more finessed answer to this question and maybe give less therapy that yields less toxicity. But we think that this treatment-free interval is actually an important metric. Now, I alluded to this earlier, but the combination therapy yields a nearly 60% incidence of grade 3 or 4 adverse events, compared with less than half of that for nivolumab alone or ipilimumab alone. And this is an important consideration as we try to decide between single agent or combination treatment for patients with newly diagnosed metastatic disease. And we don't yet have a biomarker that drives us, so we really rely on our clinical instincts. How advanced is the disease? Is it just in the lung, where studies that are being led by Alex Shustari from our group indicate that PD-1 blockade alone may be enough? Or is it in difficult to treat organs like brain or liver or bone, where the combination may be important? And then other aspects of basic patient care. How much reserve does a patient have for the additional toxicity? Are they more infirm? Are they elderly? Do they have comorbidities that would make the toxicity a bit more difficult? There are now additional schedules that are being explored. Mike is actually looking at an adaptive dosing schedule where patients receive just 2 doses of the combination rather than 4, and then cross over to single agent if they're showing any evidence of disease stabilization or response. And we really look forward to hearing about that early data from him. And there have been reduced ipilimumab dose containing regimens that have been explored, which do indeed show that if you flip the doses from ipilimumab 3 to ipilimumab 1 and nivolumab 1 to nivolumab 3, you can lower the toxicity profile. In a near-term look at survival, there does not seem to be a difference in survival with the lower dose of ipilimumab, but the response rate is modestly lower. So I think we're still grappling with what the right dose and schedule is to use for the combination in melanoma, and I think time will tell through creative trial designs, such as the ones that Mike is exploring. I just want to remind everyone that the treatment of brain metastases has actually improved in melanoma as well. As many of you know, this has been a very difficult problem for us. Certainly the emergence of stereotactic radiosurgery did improve outcomes for patients with melanoma brain metastases significantly over the 20 years that we've been doing that here. But now we know that for patients with small asymptomatic brain metastases, the ones that are really too small for the radiation oncologist to accurately target, we can treat these patients with immune checkpoint blockade with a short-term look to make sure that the brain metastases are not getting larger and need radiation therapy. So this is some recent updated data from Georgina Long, where it's actually quite clear that if you look at patients treated with the combination alongside nivolumab alone, there is an improvement in the intracranial response, and in fact the intracranial response, if you add up the CRs and the PRs in this small study, is nearly the same as the extracranial response that we've seen in the large randomized trials. And this is just showing you in this trial what the extracranial response is. So we actually are quite comfortable now starting with immune checkpoint blockade for patients with very small, just a few millimeter asymptomatic brain metastases, again with a short, like 6-week follow-up MRI. This just shows you the overall survival. I'm going to go through this. I want to spend a couple of moments here talking about some interesting imaging studies that we've done here. This is a trial that was led by Mike along with Nita Pandit-Taskar from Nuclear Medicine. And it gets at an important question that we've had of how do you distinguish between a tumor that perhaps is appearing larger on earlier scans because it's more full of T cells from a tumor that is appearing larger on early scans because there are simply more tumor cells. This was a conundrum for us, especially in the ipilimumab monotherapy era, where actually up to 20% of patients would have these pseudo-progression type of events, which were very difficult to interpret. So working in collaboration with Imaginab, which is a company that was spun out of UCLA by Dr. Wu, we have been investigating a CD8 minibody, an antibody fragment that binds to CD8. It's labeled here on site by the nuclear medicine team with zirconium-89, and it is a way to look at T cells in tumors. And again, this was just published by Nita and Mike, and these are just 5 patients looking at the early scans, and what you can see is that the early scans show that the CD8 minibody is taken up in organs where you would expect to find T cells, in lymph nodes, in spleen, and in bone marrow. However, if you look specifically at later time points in tumors, you actually can see some quite interesting things. This is a patient, I believe, of Mike's who had a long-standing response to a checkpoint blockade, but with persistent FDG-avid lesions on standard PET imaging here in the soft tissue. And what's quite interesting is that you can see this on FDG PET, but you can also see the lesion on the CD8 minibody zirconium PET, implying that this is perhaps a picture of what Bob Schreiber would term equilibrium, that this is a tumor that is actively being infiltrated with T cells and is being kept really in check by that. just showing you that it's not just a melanoma finding. This is a patient with hepatocellular carcinoma where also 2 tumors in the liver could be imaged using the CD8 immunopet. So we look forward to further studies where this can be prospectively validated really with biopsies showing that there are actually T cells in the tumor. So I'm going to spend the last 15 or 20 minutes talking about other immune checkpoint pathways or immune regulatory pathways that are of interest to us both in the laboratory and in the clinic. And over the past 10 or 15 years, we've become aware that there are numerous sort of interfaces between the immune system and tumor cells, different sort of either activating or inhibitory levers that can be pulled to try to coax the immune system into responding better to the tumor. And this was nicely depicted in this diagram from Dan Chen and Ira Melman from Immunity. Both of the pathways I'm going to speak about are members of the TNF receptor family. One of them is called GITR, glucocorticoid-induced TNF receptor. GITR was actually identified by Professor Shimon Sakaguchi from Osaka University, who identified it as a selective marker of regulatory T cells. And for the non-immunologists, regulatory T cells are very much the work of Sasha Rudensky, who identified the molecular pathways which drive their suppressive phenotype. And they have been a very difficult population of cells for us to combat therapeutically. Patients with advanced cancer have higher numbers of regulatory T cells in their peripheral blood, and there can be many of them in the tumor microenvironment as well. So when Dr. Sakaguchi identified GITR as a somewhat selective marker of regulatory T cells and generated an antibody to GITR, we were actually quite interested in exploring this. And he kindly shared with us this antibody, which is a rat anti-mouse antibody called DTA1. In some early studies done in our lab by Adam Cohen, who's now at Penn, and David Scher, we actually found that the GITR antibody, which DTA1, given just one time, could lead to the regression of B16 melanoma in about half of mice. And this was actually the most potent intervention that we've seen against B16, much more potent than CTLA-4 or PD-1 blockade. And so therefore, we were quite interested in understanding what the mechanism underlying this is. And in the flow cytometry plots, looking at tumor-infiltrating cells, we noted that there was about a 50% decrease in the number of regulatory T cells in the tumor. And this led to a favorable skewing of the CD8 to Treg ratio, really only visible in the tumor, as well as an effect on an infusion of adoptively transferred CD8 positive T cells recognizing the melanoma antigen GP100, where in the presence of DTA1, these cells become sort of superactivated. Well, what happens to these regulatory T cells after they see this, this anti-GITR antibody, which again is an agonist antibody? So some of them may actually be depleted, but when we've done studies with antibodies or antibody fragments that don't deplete, we can actually still see activity. So there's more to the use of this antibody than just an antibody-dependent cellular cytotoxicity. And what we've actually uncovered is that GITR agonism in this case leads to a loss of the lineage commitment of regulatory T cells to this inhibitory phenotype. So translated, the Tregs stop behaving like suppressive cells and start behaving like activated effector cells. And in a Treg transfer experiment using Sasha Rudensky's FOXP3 GFP mice, which we used to transfer regulatory T cells that are then exposed or not to DTA1, we showed that these regulatory T cells, after exposure to DTA1, start making interferon gamma, which is very much a hallmark cytokine of effector T cells and not regulatory cells, and stop making IL-10, which is very much a hallmark of regulatory T cells and not effector cells. So we think that these, this shows us that the Treg phenotype is plastic, and depending upon the signaling, in this case through TNF receptors in the tumor microenvironment, we might be able to not necessarily just deplete these cells, but to actually cause them to change their function. And so we were quite eager to explore this in clinical trials. We were actually the sole site for many years conducting the first in-human trial of a monoclonal antibody called TRX-518. This was one of the first studies opened in the ITC quite a few years ago. And this TRX-518 is an aglycosyl humanized agonist antibody to GITR. Its aglycosyl nature means that it does not engage with FC receptors in any type of a functional manner, so it cannot convey an ADCC activity. So anything that we see is not due to antibody-mediated depletion, but perhaps due to the sort of change in lineage commitment, which I described previously. This underwent probably one of the longer phase 1 trials. We were in trouble with the IRB multiple times here. The study was MSK 10147, and it just closed a few months ago. And that was actually due to a few influences. One was financial toxicity. The company went out of business a few times, and so we had to wait for it to be rescued. But also, this was the first agonist agent to enter clinical trials after there were near deaths and deaths on other agonist antibody trials. There were near deaths on the CD28 trial, and there were 2 fulminant hepatic failure associated deaths from the CD137 agonist antibody trial. So this entered the clinic at a time when there was a lot of, I think, appropriate worry about the safety, and so it was a very low dose that was started with, and it was a single ascending dose trial with long DLT windows. So there was a lot of reason why this took a long time. So to make the clinical part of this story short, we saw no objective responses to the single dose of anti-GITR. We saw no treatment-related high-grade toxicity either. But what we did see is some very interesting pharmacodynamic data, which was recently published by Roberta Zapasati, who's a very talented postdoc in our group who is joining the faculty at Weill Cornell imminently. And I'm just going to highlight some of that right now. So this is a snapshot of the patients who were enrolled on this trial. You can see it was a mixture of patients with different refractory solid tumors. The patients highlighted in gold were those patients who really generously volunteered to have paired biopsies done, so we could look at regulatory T cells in the tumor microenvironment as well as in the peripheral blood. This is looking at the peripheral blood, and what you can see is that the only cell populations that change over time with treatment are actually regulatory T cells, Tregs, and most specifically GITR-positive Tregs. And it's important to note that the antibody that we use to detect GITR in this flow cytometry panel is not cross-blocked by TRX-518. So this is a true decrease in these cells and not simply cross-blocking. When we looked in the tumor specimens, which are shown over here, we could see that there was a decrease in the number of regulatory T cells in the post-treatment biopsies compared to the pre-treatment biopsies. And these colors are correlated between the tissue sampling and the peripheral blood sampling. So these 2 patients in blue who did not have a decrease in the peripheral blood Tregs also were the ones who did not have a decrease in the intratumoral Tregs. And this is just an example of one of the multiplexed immune fluorescence results that was shown. So this leaves us with a question as to whether a concordant downregulation of Tregs in the peripheral blood after TRX-518 was really not sufficient to obtain substantial clinical response. Why is that the case? And so we really returned to the mouse models to dig into this a little bit deeper. I just want to remind you that when I first showed you that anti-GITR data, that was in mice that had a tumor that was 4 days old. If you look at that, you can see a very nice response compared to control. But if you let that tumor grow to 7 days then treat with anti-GITR, you have absolutely no activity. So this really opened up the opportunity for looking at these 2 settings as a way to understand why patients might not respond to anti-GITR. And so the simplest explanation, which Roberta looked at, was that there simply is no ability to decrease regulatory T cells in mice with more advanced tumors. And that turns out not to be true. There is a very favorable effect on regulatory T cells, even in the 7-day-old tumor. So then the question becomes, and you can post this, I don't care, I just forgot to strip this off. Roberta then went and looked in the CD8 positive tumor infiltrating lymphocytes using gene expression analysis, and showed actually that if you compare the day 4 anti-GITR with the day 7 anti-GITR, there's quite a striking difference in gene expression. The day 4 anti-GITR had low expression of these exhaustion markers, which actually PDCD1 is PD1, and LAG3, which is another exhaustion marker. The day 7, much higher. So this implied to us that perhaps at later time points, getting rid of Tregs was not sufficient, and we needed to also combat the infiltration of the tumor with exhausted T cells. And so that was, I think, a rational reason to block PD1 in addition to agonizing GITR. And when that was done, you can see that even in this late tumor, there was very nice anti-tumor activity for the combination. And when we looked at the gene expression, there was a reversion of this exhausted phenotype. Now we see low levels of LAG3, PD1, and another inhibitory marker, TIGIT, when both pathways are blocked. In work done by Sadhana Budhu in our lab, who has developed a very nice ex vivo tumor killing assay, we can see very high levels of B16 killing, even with the day 7 treatment when the combination is used as opposed to anti-GITR even at day 4. So this has given rise to combination trials of anti-GITR plus anti-PD1 by itself, and then in a trial that Alison Bethoff-Warner is leading here in the ITC, the triple combination of cyclophosphamide as well as anti-GITR and anti-PD1. So I'm just going to finish up for 5 minutes with another pathway that we have interest in, which is the OX40 pathway. It's another member of the TNF receptor family, and this is very much the work of Daniel Hirschhorn, a senior scientist in the laboratory. We have an antibody to OX40, which is called OX86, which by itself does absolutely nothing to mice that have B16 melanoma. However, if you combine OX86 with the chemotherapy drug cyclophosphamide as a way to reduce the number of regulatory T cells and also to induce homeostatic proliferation of immune cells, so in sort of an analogous way to the way that cyclophosphamide and fludarabine are used as conditioning for cell therapy, if you use that along with the OX86 antibody, you can regress about 10-day-old B16 tumors. However, if you go with a 21-day-old B16 tumor, and this is just about when you get in trouble with the IACUC, you need to up the ante quite a bit. And here, because OX40 is very much a CD4-directed marker and pathway, we've also done an adoptive transfer of CD4 cells which are directed against TRP1, a melanosomal membrane protein, also known as GP75, which was actually discovered here at MSK by Lloyd Old and Alan Houghton's groups. And so using transgenic mice that have CD4 cells that recognize TRP1, and these were from Nick Restifo at the NCI, this combination can fully regress all of these tumors. Now, what's interesting in considering this combination is that when we rely upon a cell therapy that only has specificity for a single antigen, we open up the opportunity for the emergence of antigen escape variants. And this has very much been the case with CD19 CAR T cells, where you see CD19 negative variants emerging. And so we tried to model this using a B16 variant called B78H1, which does not express TRP1 antigen and also does not express MHC molecules. And what you can see is that it grows very nicely as opposed to B16 with this triple therapy. However, if you make a chimeric tumor, 50-50 mix of B16 and B78, you actually can cause a very nice regression of almost all of these chimeric tumors. But if you implant the tumors on other opposite sides of the mouse, there is no abscopal effect, if you will, on the distant B78 tumor, implying that there is a bystander killing effect, but there is no antigen spreading. And so we want to understand this bystander killing effect. And in doing so, we noticed actually that after long periods of time that these mice are alive, we see toxicity. We see not only a depigmentation of the mouse's coat, which is sort of the analogous phenomenon to vitiligo in humans, and this is understandable because we're targeting a protein found on melanocytes, but in addition, we see inflammation of the ears, the periorbital areas, and the snout of the mouse, which sometimes even lead to the ears falling off. And these are the most melanocyte-rich areas of non-haired skin in the mouse. And you can actually quantify this by just simply measuring the thickness of the ear pinna. And what's interesting is that the T cells are actually not necessary at all time points to mediate this. So if you deplete the CD4 T cells early, yes, you actually lose the tumor control, and yes, you lose the activity in terms of the ear thickness. But at later time points, at day 12, if you deplete T cells, you really do not lose the anti-tumor activity shown over here, and over here you still have the ear thickness. So what this is telling us is that T cells are required early for both the ear thickness and the tumor regression, but T cells are not necessary at later time points. So what cell types are necessary at later time points for both the ear inflammation and also the anti-tumor activity? So to study this, Daniel actually prepared a homogenate of the ears, which he conveniently terms ear juice, and subjected this to protein array analysis, and actually found that over time and in an OX40 dependent manner, there is an innate immune signature which emerges. And so this opens up the possibility that this is due to macrophages and macrophages and neutrophils. And in fact, we see Ly6G positive cells at later time points in an OX40 dependent manner. Now, this also opens up the possibility that depleting neutrophils is a way to blunt the toxicity and with an unknown effect on the anti-tumor activity. So if you look at the ear thickness when you block neutrophils using an anti-Ly6G antibody, you can actually decrease the ear thickness from here to here. But you have absolutely no impact on the anti-tumor activity against B16. Now remember, B16 expresses the antigen, and so we wouldn't necessarily need the bystander killing for B16. But if you look at the chimeric tumor, the B16, B78H1, where only half the tumor cells express the cognate antigen, and you use isotype versus anti-Ly6G, you lose the control of these tumors at later time points, perhaps because neutrophils are playing a role in this bystander killing activity. And this gives rise to a model where the early infiltration of T cells leads to inflammatory cytokine release, which then recruits innate immune cells such as neutrophils. Neutrophils may participate in tumor cell killing as well as tissue destruction through phagocytosis, through cytotoxic granules, and also perhaps through the creation of something called neutrophil extracellular traps, or NETs, which are extruded citrulliнаted histone-laden nucleic acids that are sort of sprayed out as a way to trap pathogens. And through a collaboration with Michaela Egelblad, we've been able to actually visualize NETs in the ears of mice and in tissue specimens shared with us by Mario Locatore from patients with rashes. So I'm going to finish up there with a couple of minutes for questions. I think I covered all these points, but I want to just thank some folks who participated in this work. So the co-head of our lab is Tahar Margoub, who's here in the audience. I'm very grateful to him for all of his partnership and leadership over the years. Roberta Zapasati, who did the GITR work. Daniel Hirschhorn, who did the OX40 work. Sadhna Budhu, who is our expert in cell killing. I really could not have done any of the clinical work on CTLA-4 and PD-1 blockade without the enormous input from Maggie Callahan and Mike Postow, and Nita Pandit-Taskar from nuclear medicine. Of course, patients and their families for participating in the clinical trials, all the people that pay the bills. But in addition, some other folks that I wanted to especially acknowledge. I think last night, both Paul and I paid tribute to our once and always mentor, Alan Houghton, who has been an enormous influence on the melanoma service and really has helped us to build this family. And Paul, of course, who has been a friend, a mentor, and a wonderful colleague. Phil Livingston, who was really one of the first believers in immunotherapy here on the melanoma service and who made a brief flyby last night at the alumni. And then the current members of the melanoma service that I didn't acknowledge before, Alex Shustari, Alison Betoff-Warner, Parisa Momtaz, and Afshin Iqbal, who is kind enough to see our melanoma patients in Basking Ridge, even though she probably identifies herself more as a lung cancer doctor. Importantly, none of us can do this alone. We're very dependent on the other members of the melanoma DMT, our surgeons, radiation oncologists, dermatologists and pathologists, the wonderful nurses and APPs who we count as family members, as well as, of course, our research and administrative teams. Thank you so much again. Any questions? No. All right. Thanks.